to talk about perimenopause. Let me start off by sharing my slides. So my topic for this afternoon is about navigating perimenopause, embracing changes with menopausal hormone therapy. Now, it is really important. Perimenopause has become so important because this is the time that a lot of women are actually suffering and have got no one or nowhere to turn to, and are totally not sure of what to do with themselves. Now, these are my disclosures. I do talk about menopause with a lot of companies, for a lot of companies, and I am getting an honorarium for this talk, but let me reassure you that all the contents and thoughts and viewpoints here this afternoon are purely mine. Now, why has menopause and perimenopause become so very important? And that's because the fact is that many women, around 26% of women and more, are above the age of 50 and are going through that menopausal transition or are already menopause. Now, when I first started talking about menopause many years ago, I usually used to say that over 1/3 of a woman's life is spent in the post-menopausal phase. But let's look at the actual numbers. In Vietnam today, your menopause age is 48 to 50 years, and that means that woman has stopped her periods 1 year before. The life expectancy of the Vietnamese woman today is around 80 years. So if she stops her periods at around 47, 48, and she lives beyond the age of 18, then we are looking at the fact that a lot of women, 40% or 50% of their lives, are actually in a state of estrogen deficiency. So it's no more that 1/3 that we should be quoting. So looking again at the Vietnamese health statistics, cardiovascular disease, which includes strokes, which includes ischemic heart disease, accounts for more than 31% of deaths. A lot of the risk of diabetes is increasing at an alarming rate in Vietnam, doubling over the last 10 years. And we are looking at both men and women. We are also looking at the fact that men and women in your country and my country in Malaysia, when they get to be above 75 years of age, 1 in 4 of them will be getting cancer. Now these are very, very scary stats, and for women, a lot of these changes are actually beginning at that perimenopause. So when again we look at perimenopause and we look at that menopausal transition zone, we can actually divide it into the early transition zone and that late transition zone. So we know that the perimenopause can start with a little bit of cycle changes, more than 7 days per month, every month, a lot of changes which may be early by 7 days, later by 7 days and more. And then they go on to intervals of 2 months, 3 monthly period cycles, and they then go on to slowly reaching menopause. So this transition zone of cycles changing slowly from early perimenopause to late perimenopause, this is when the symptoms are already starting. This is when changes are already happening inside their body. And why is that happening? Because of the fact that this is that time, this blue swinging zones which actually depict that estrogen levels going up and down, are already bringing a lot of changes to that particular woman. So there's really sometimes no point doing an estrogen level at this time or an FSH level at this time because of the fact that This swinging hormones will never be picked up sometimes. Today, their levels are good. Tomorrow, their levels are low. The next day, it can be actually high. But what it actually means is the fact that these women are now going through a lot of changes which makes them feel very uncomfortable with their body. So now, when we look at aging, and we're talking about chronological aging, as in how old are you today in terms of your birth date, that's that chronological age. But we know that there is another kind of aging that we need to be worried about, and that is biological aging, which means that you may be 40 years old, but if your cells are not kept well, you may be actually older than your chronological age of 40 years. So your cells may be 50 when if you have not looked after yourself well. Or if you have looked after yourself well, you might be 35 or 38. But what happens when a woman goes through estrogen deficiency? Menopause comes in, and this actually accelerates the biological aging. So her cells are much older than what it should be. And this is where that problem is. A woman may be 45, but the cells in her body may be 47, 48, and this causes more problems along the way. So with perimenopause and that swinging estrogen, we are talking about symptoms, hot flushes, this sudden explosion of heat that comes in, the sweating at night that does not allow her to sleep, the mood changes, the anxiety, the panic attacks, the memory changes. She feels that, oh my God, I'm going to get dementia very soon. The headaches, the migraines, the general aches and pains, joint pain, which is the leading symptom of perimenopause and menopause in Asia, the muscle loss, sarcopenia, all that vaginal changes, which means the vaginal dryness, the bleeding after sex, the itching that comes in, the urinary bladder changes such as urinary tract infections, dysuria, frequency of urine, the weight changes, the change in visceral fat that comes in, the abdominal circumference, the weight circumference that increase, the skin dryness, the hair loss, the brittle nails, the wrinkling, the hydration, all this which actually leads on to decrease in quality of life, it impacts her quality of life, and actually that also causes a lot of other changes in her. So let's then look at that woman going through all that changes and our role as that healthcare professional. Do we make her wait for menopause? Do we address her problems at that time? And I really think that our role as healthcare professionals is to empower that woman, how to navigate perimenopause, increase her awareness, have more open conversations with her, help manage and treat her symptoms, and make her more aware about all the problems that she may have, because we want to make her healthier as she gets older. So let's look at some of these symptoms and how important these symptoms are. Just looking at hot flushes. Now we know that a lot of women start having hot flushes during the perimenopause, but sadly 25% of women continue having hot flushes throughout her life. 50% of women actually have hot flushes up to 10 years and more. And so they are then experiencing these hot flushes, the night sweats, which make them feel very irritable with a lot of anxiety issues, waking up in the middle of the night and continuing with that. But we also know that having vasomotor symptoms is also linked with heart changes, endothelial dysfunction, increased carotid intima media thickness, and putting this woman at a higher risk of hypertension, atherosclerosis, and coronary events. Looking at the progression of carotid intima media thickness across that menopausal transition, we find that the increase in carotid intima media thickness is highest during that late perimenopause. And this is really significant because here is a woman, she's not even menopause yet, she's in the late perimenopause, and her heart changes is already there, and she is totally not aware of it, putting her at that increased risk of cardiovascular disease as she gets into the menopause. Now let's talk about that joint pains, the musculoskeletal syndrome of menopause, which has now garnered a lot of information. We know that a lot of women, 70% of women, will suffer from musculoskeletal syndrome of menopause. They go and see their doctors, and 40% of them will have no structural findings. 25% of them will have severe symptoms. This is the time that they are actually losing up to 10% of bone density during that perimenopause. They lose muscle mass, about 0.6% every year. So if that perimenopause is going to last 5 years, 8 years, they've lost a lot of muscle mass, which just then increases with time during the menopause. So women who have vasomotor symptoms, we already know that they have lesser estrogen. It can actually signal that these women with vasomotor symptoms, severe vasomotor symptoms and early onset vasomotor symptoms, may already have a lower bone mineral density and faster bone turnover. So this is how we actually pick up women who are actually probably going to have a lesser bone density. We know that a lot of women, when they have reached 5 years to 7 years after menopause, have lost 20% of that bone density, which actually starts 2 to 3 years before their final menstrual period. What about that brain fog? We know that a lot of women having that hot flushes is linked to sleep disturbances, is linked to mood swings and depression, is linked to lesser energy because they're not sleeping. All this is like a vicious cycle and decreases their quality of life. All that causes them to have that brain fog, that memory issues, and a lot of them are worried that they are going to have dementia later, and it's our role to reassure them that this is not dementia, it's because of the fact that they're not sleeping, they're not rested, and helping them through this particular phase. Depression, mood swings are really very important. Again, with that the estrogen that swings during that perimenopause, we know that the risk of depression is much, much higher. And this is something that a woman can carry through their perimenopause and into the menopause, and helping them with their symptoms actually cuts down that risk of depression and mood swings. Women are also worried about the fact that they are putting on weight during that menopausal transition. We know that the less estrogen, the less muscle mass, the less muscle mass, the less calories being burnt. And this causes more fat accumulation. And the fat accumulation that we are worried about is the visceral fat. The fat that then goes around the liver, goes around the heart, and causes more problems. The menopause belly is visceral fat, metabolically very active and dangerous because it brings about the metabolic changes in the lipid profile, higher fasting glucose, higher risk of diabetes, higher blood pressure issues, again increasing the cardiovascular disease risk, increasing what we call now non-alcoholic fatty liver disease. So it's very important for women to understand that weight gain may be linked to aging a little bit, but the visceral fat that comes in is actually linked to estrogen issues and the menopausal transition. So here we are as healthcare professionals trying to help our women, through this menopausal transition. And it's really very important that they are advised to follow the 7 healthy heart habits. Looking after their weight, their blood pressure, their sugars, making sure that they do their blood tests, checking that their lipids are good and their fasting glucose is good, teaching them the correct exercises, dietary changes, healthy habits as is cutting down smoking, cutting down the alcohol intake, which is really very, very important. It's also our role not to ignore the woman who is not having any symptoms, because we still have to pay attention to her based on what are the changes that she is going through inside, which she may not know of. The cardiovascular issues, the bone loss, the cognitive decline, knowing what's there in her family history and making sure that she's kept aware and kept coming back for all the tests that are necessary. But let's look at that symptomatic woman, the woman who is actually suffering, because we know that we need to take her seriously. We need to offer her non-hormonal therapy. We need to offer her menopausal hormone therapy so that she has that quality of life. So now coming back to that question of should menopausal hormone therapy be offered to all menopausal women? And I will be the first to say no, not everybody needs it. But it is our role to help that woman who is suffering through that menopause, that younger, healthier woman in that perimenopause and menopause who is symptomatic such as vasomotor symptoms, sleep issues, tiredness, brain fog, mood changes, generalized joint pains. These are the women that should be offered menopausal hormone therapy. And we know that vaginal estrogens help them with that genitourinary syndrome of menopause. And we also know that hormonal therapy would help not only with looking after their lipid profile, cutting down their risk of diabetes, but also prevention and treatment of bone loss. So now coming back to hormonal therapy, we are dealing now with body identical hormones, which means that these hormones, estrogen that we are using is as the same structure as the body hormones and is the gold standard of hormone replacement therapy. Naturally derived as possible, safe, we have well-conducted research and we have data to back it. We know the numbers to tell our women. We know all about the low dose, the normal dose therapy. We can give them, we can reassure our women that we are dealing with the safe hormones. And when we are talking about estrogen, we are dealing with the estradiol. And let's not ignore that some women also need to have different options, because not all hormonal therapy is standard. We always offer them the estradiol as first line, but there are women that may not be suitable for estradiol and may actually look at different options, and then we go on to the conjugated equine estrogen, the conjugated equine estrogen or the ethinyl estradiol, but always using the natural estradiol as the first line. The progestogens that we are looking at could be the micronized progesterone or the dydrogesterone, and here we have the various activities. They are both progestogenic and anti-estrogenic, but differ in the form of androgenic, anti-mineralocorticoid activities, and GABA. The advantage of the micronized progesterone is the fact that it has a GABA action. The advantage of the dydrogesterone is the fact that it is it has got no androgenic activities, it has got no glucocorticoid activities, and it is highly selective for progesterone receptors. So in many ways, having an option always helps us choose the best kind of hormone therapy for that woman, because we know that every woman is different and we need to understand what she is going through and choosing the best type of hormone therapy for her, and what we call individualized hormone therapy. So having that option of different types of hormones makes us choose the correct hormonal therapy for her. So we know that we have the oral estrogens, we have the oral progestogens, we have the non-oral estrogens, as in estradiol gels and sprays. We have the non-oral progestogens, such as the vaginal progestogens. We have the intrauterine levonorgestrel system. We also have a completely different type of hormonal therapy, which is the gonadomimetics, which is actually tibolone, which acts as an estrogen, progestogen, and testosterone. So having this whole bag of different types of hormone therapy helps us then choose the correct one for her, of course looking at what her side effects are and then getting her to have the best kind of hormone therapy. We also know that we have to give the hormones according to the history that she is giving us. So if she does not have a uterus, she only needs estrogen, or we can then give her tibolone. If she has her uterus, then we need to find out whether she is in her perimenopause, that means she's still getting her periods irregularly, or is she in the menopause and she stopped having her periods for 1 whole year. So depending on whether she is in the perimenopause, which means that the type of hormonal therapy that we would give her would be estrogen every day, but the progestogens would come in 12 to 14 days in the month. If she is now in the menopause, she would get estrogen and progestogen every day, and this is what we call the no-bleed therapy. We also know that women with, who are now in the menopause can also go on tibolone. So how would we then choose doses? We always start with a low dose first and increase only if necessary. So this is a very, very important chart, which basically means no uterus, only estrogen or tibolone. With the uterus in the perimenopause, we need to give her regular scheduled bleeding, which means that estrogen daily and 12 to 14 days of progestogens a month. If she is clearly in the menopause, it would be estrogen and progestogen every day. Now, in Vietnam, I know that you have preparations which have got estrogen and progesterone in a cyclical form, or what we call sequential therapy. And it is really very easy because we have different colors to also aid us. We have the low dose therapy, and I will show you the normal dose therapy later. You have Famastone 110, which means that the woman gets 1 milligram of estrogen every day, and 14 days of estrogen and progesterone in the 3rd and the 4th week. So if you look at this particular cycle, the white tablets are pure estradiol. The gray tablets would be estradiol in combination with dydrogesterone. So really very easy to tell that woman to start on that first day of her period, or if she's having very irregular cycles in the late perimenopause, she can start anywhere. So following that arrow at the back, finishing off all her white tablets first, and then going on to her gray tablets, and immediately starting off with the next pack. So she would get regular bleeding every month. She gets her estrogen every day in the form of 1 milligram estradiol. She gets progesterone in the second half of the packet for 14 days in combination with estradiol, and the progesterone here is dydrogesterone. Now, we can also have the normal dose therapy, which is actually different in color. So again, looking at 2 milligrams of estradiol, the red tablets here, followed by the 3rd row and the 4th row, which is 2 milligrams of estradiol in combination with 10 milligrams of dydrogesterone. This is now going on to sequential therapy again, but a normal dose, not a high dose, a normal dose, again giving her regular bleeding. So now, when do we start low? When do we start a normal dose? And we will always say, start low, get her used to it, and only increase if necessary if her symptoms still persist after 3 months. Again, if her symptoms go off and then come back, look at always life changes, other stresses that can actually cause her to have more symptoms. Always remember that women's hormones are changing as they go on from the early perimenopause to the late perimenopause, and this is why sometimes we have to actually increase doses. And in the worst case scenario, if even the 210 does not satisfy her or treat her symptoms, we may have to go on to other modes of therapy. Individualizing therapy is the most important. Menopausal hormone therapy would help with her periods, would help with her vasomotor symptoms, would help with her sleep, brain fog, improve her tiredness, change her moods to be better, help her prevent and treat bone loss, improve her vaginal health, joint pains, and of course, quality of health becomes so much better. Her cholesterol becomes better, her risk of diabetes becomes better controlled, her blood pressure becomes so much better. So menopausal hormone therapy will definitely help that woman in transition. But we are always worried, aren't we, about all the data that was there so many years ago. And as doctors, we are always a little bit more cautious. But let me reassure you, all that meta-analysis that has come on with after WHI has actually taught us a lot more. We know that the cardiovascular risk is so low and is almost negligent in a woman who is starting hormonal therapy in the early phases. That means in the perimenopause and in the less than 10 years after menopause. She clearly falls to the left. So we don't have to worry about the fact that these hormones actually increase her cardiovascular risk. Actually, it decreases her cardiovascular death risk. And now, interestingly, data that is now coming in initiating menopausal hormone therapy after 10 years of menopause, showing clearly that it is not even associated with a higher cardiovascular death risk. So clearly putting that woman into a better place. So again, what we need to do as clinicians is to always evaluate her as a whole. What is her inherent risk from her family history? What is her risk as she stands today? Is she overweight? Is she sedentary? Does she already have cardiovascular risk factors which are really very strong? And then modifying it with lifestyle, modifying it with the correct hormonal therapy for her. Observational data is all good news with diabetes because we know that there is a 30% decrease in diagnosis of new type 2 diabetes in women who are on hormonal therapy, and women who are already on hormonal therapy. There is a 36% reduction in fasting glucose, which is great news for diabetes and menopausal hormone therapy. What about the risk of venous thromboembolism? And this comes from oral. VTE risk is clearly higher with oral estradiol, oral conjugated equine estrogen. And this has been shown from this huge data of 100,000 over women that came out in 2019. Again, clearly showing that when a woman goes on estradiol and dydrogesterone, which is what Femistone is all about, there is no increased risk. So you have all that safety data there. Transdermal estradiol, transdermal combined menopausal hormone therapy, and Tibolone showing no increase. But as I said, does she have other factors? Obesity, sedentary lifestyle, previous VTEs or previous history of malignancies, family histories of VTE, factor V leader mutation. So having that history with you then helps you then choose the right kind of menopausal hormone therapy for that particular woman. But women are also, not only women, but doctors are also very worried about the breast cancer risk. And again, we have so much more data now showing that estrogen only does not increase your risk for breast cancer in women who have been hysterectomized. When we add progesterone, we need to add the correct progesterone. And we now know that dydrogesterone, which is again there in your Femistone, and micronized progesterone is linked to a lower risk of menopausal hormone therapy associated breast cancer. We know that, so the safer hormones or the safer progestogens to use always is that dihydrogesterone and micronized progesterone. And this is data from Europe, from France, from Finland, again showing that we are now very well versed with which kind of progestogens to use. But again, we need to evaluate our patients as a whole. Are they overweight, putting them at a higher risk of breast cancer? Do they take more than 2 glasses of alcohol every day, putting them at a higher risk of breast cancer? Smoking, exercise, again, putting them at a different pace, at a different risk of breast cancer. So evaluating that woman as a whole is very, very important. So again, ladies and gentlemen, I am going to end here by saying that every woman is different. We have the women without symptoms coming to us. We have the women with symptoms coming to us. We have that perimenopausal woman who is suffering with all sorts of issues. We have the menopausal women that is suffering with all sorts of problems. Now, our role as healthcare professionals is actually to evaluate every woman in front of us and help her get her through that menopausal transition into menopause and beyond, because our role is to give her that quality of life. It is very important for us not only to talk to her and increase her awareness about menopause, but also to talk to her about lifestyle changes. Is there a role of herbal products that can help her through some of her mild symptoms? Does she need prescription therapies to help her through mood changes and depression? We also know that there are newer therapies which are non-hormonal, which are going to come out soon in this part of the world, that is going to help her with her vasomotor symptoms. What are the role of supplements? How do we help her through her getting her vaginal health much better? Does she need counseling, mind-body techniques? And I think it is really very important to have that conversation with her, whether we are going to go through hormonal or non-hormonal pathway. Helping that woman in front of you becomes very important. And I'm very happy to be here again virtually with you, and very open to all the questions that you have for me later. Thank you very much again.